Okay, so this is Mr. Garcia. So he is a 30-year-old male and he is interested in donating blood at the local blood drive. So there are going to be details of, let's see if I can do a little draw. So there are details of Mr. Garcia here. So he has a temperature of 98.6. He has a height of 5'10". He has this weight. He has this age. Here's his blood pressure. He has this hemoglobin level. He does have a history of drug use, and it looks like it was about 2 years ago. So looking at this, is there really anything that's going to rule him out from donating blood, and why or why not? So looking at this, if you look at the temperature, he's 98.6. So the patient that is donating blood must have a temperature under 99.5. So he's okay here, and I'm not going to stop. I'm going to stop doing these little stars because I can't draw worth anything. And there is no height criteria, so that's fine. His weight is 175, and so any patient that is over 110 pounds over 18, that is fine. There are additional criteria for a patient that is under 18 years old, but you don't have to learn that. For me, just be aware that there are additional criteria for a client under 18. So most states, a patient 17 and older can donate blood. He's 30, so we're good. There are some states that allow 16 and above with parental consent, but just no 17 and older, most states. So blood pressure, there are particular criteria for donating with your blood pressure. You can't be too high or too low. So his actually does fall into our range, and the range for it is there's a systolic range where it is 90 to 180 and 50 to 100 diastolic. So there really isn't a pulse rate, respiratory rate, but it would clue us into if the patient was feeling ill. So the patient feeling generally ill would be they need to feel generally well. They cannot be generally ill and donate. So this would clue us in if there was anything going off. His are fine, so we would say that he's okay as far as that goes. And the hemoglobin level is 14.5 for a woman or for a female, and this is their genetic, they're assigned at birth, female, male. Because we're looking at physiological function. So his hemoglobin level as a male would need to be 13, and as a female, it would be 12.5. So he's okay as far as that goes. So we're checking on that. And then the history of drug use. So he does have a history of drug use according to this, but it was 2 years ago. And it doesn't look like there was any needle use. So our real concern with the history of drug use would be that sharing of needles, which would put us at that higher risk of getting like a viral transmission, a bloodborne illness. And it needs the thing that would keep us, contraindicate us for donating blood would be within that last 3 months. So really here we're fine as far as that goes. Some things, so if he were to have a use of needles, drug use with needles within the last 3 months, any unprescribed drug use with needles last 3 months, that would be a contraindication, but he's fine. So we would want to ask some other questions though. We would want to make sure that he was still feeling well, because remember, if he was feeling ill, that would be a contraindication. We would want to ask about some of his past or his current medications, because if he was on blood thinners, that would be a contraindication. We also would want to ask about his medical history, because there is a contraindication with some psoriasis medications. We would want to No, we would need to ask about if he has had any sexual relationships with men in the last 3 months, because whereas they used to not allow any men that had sexual relationships with men to donate blood, they have opened this up to allow men to donate, but they still do not allow men to donate if they've had sexual relationships within the last 3 months. And that is just because there is an I guess, an increased risk of HIV transmission with male-on-male relationships. So they have that 3-month waiting period for them. And then they have also, you also need to make sure that they have not had any, they have not had any sexual relationships for money or drugs within the last 3 months as well. And I believe that would be the other questions that we would need to know as well. So we're kind of looking at the processing as well. And this should say type and screen, difference between a type and screen and a cross match for a unit of blood. So what is the difference between those, and why do we need to do both? So you would want to do a type and screen for a unit of blood, because that makes us able to identify units of blood that are potentially available that would be used for a patient if we should need it, whereas a type and cross match means that we have a compatible unit of blood available for our patients. So a type and screen is usually done for a client when we're just kind of like, we might need units of blood. Let's go ahead and identify our client's blood type and identify potential donor blood that's available for a client, shall we need it. So sometimes you would do this if a client comes in and you're worried that they may be losing blood, or if they have a surgery and you're worried that they may have blood loss. So it's not a patient that you think is going to absolutely need a transfusion, but there's a potential for a transfusion. So you would do a type and screen. And then what you do is you have the lab or the blood bank, they will come in, they will draw the patient's blood, they will identify their blood type and their RH factor. So, O positive, O negative, A positive, A negative, B positive, B negative, AB positive, AB negative. So whatever that is their type. And then they will go and they will identify what blood they have that is compatible or potentially compatible with the client. They do not mix that blood and look for any potential antibody formations. So it's just having it kind of on standby should they need it, but they don't 100% expect it. With a cross match, we expect to get the transfusion, we're preparing it and getting it completely ready. So with the cross match, we expect to get the transfusion. They take the donor's blood and they take the recipient's blood and they actually mix it together and they watch and make sure that no antibody formation happens. And so that way they can make sure that there is no reaction before that. So they make sure that there's actual compatibility, and that can prevent those reactions from happening. So that cross match is really just to prevent that reaction from occurring and identifies any potential antibody formation prior to setting it up and getting it to the client. So then the next question we have when we're looking at and it's kind of weird because really that should have went farther in there, because you don't type and cross match till way later, because you do nucleic acid amplification testing way earlier in the process. So this is when Mr. Garcia goes and he donates the blood. They do the nucleic acid amplification testing way before that ever gets anywhere near the client. So they do this batch testing where they have this very specific DNA testing that can be done. So it's able to identify very low levels of DNA. So whereas a lot of your testing that you see out is looking for antibodies against viruses, this can actually detect very small levels of the DNA. So it's very important because this way it's able to spot the viruses like the HIV and the hepatitis C, and it's able to catch that at very, very low levels so that it is a very, very minute risk to clients. And that's why we see these very small risk of transmission to those that are getting these blood transfusions. And that's, if you look back in the mid 80s, you can see stories of people that were getting HIV from blood transfusions, and you really just don't see that happening like you did in the past. And so there's still going to be a stigma of that out there, and people, and the risk is still not absolute zero, but the risk is just very, very, very slim now because we have this NAT testing happening at a very specific level now. So it's very important because we can catch it when there's very low level of virus in the blood, and we're able to not put that blood out and transmit that to patients. What must be considered when you're deciding if a donor and the recipient blood is compatible, and why is important? And really the main thing that this is triggering you to look at is going to be the blood type and the RH factor. There are going to be other things that are going to be at the surface of the cell that you're going to see on cross matches, and that certain clients are going to have, that certain clients are just going to have. But by and far, the blood type and the RH factor are going to be the most important thing. And you must know that you can never ever give somebody something that they do not have. So if I have no antigen, so if I have an O, that means I have no A, I have no B. If you give me either of those things, I'm going to form an antibody, and it's going to cause destruction and damage. If I have no antigen, I'm sorry, RH, that means if you give me that RH factor, then it's going to cause that antibody, and it's going to cause the agglutination, it's going to cause destruction. So remember, you never can add to, because my body will see it as foreign and start attacking. So it's very important to consider the compatibility of the blood type and the RH factor whenever you're looking at compatibility for blood donation. Okay, this is Mrs. Thompson. So during a busy shift in the medical surgical unit, you, a registered nurse, are tasked with administering a blood transfusion to a 70-year-old female patient, Mrs. Thompson. And she was admitted with a GI bleed secondary to a peptic ulcer, and has a hemoglobin level of 7.8. She has a B negative blood type. She has an order for a transfusion of 2 units of packed red blood cells. So the following interventions are completed. So first of all, assess the transfusion knowledge and history of the past reactions, educate the client on the process, and obtain consent. Place a 20-gauge IV catheter. Prime Y-type blood tubing, normal saline. Set up secondary infusion line to piggyback through primary blood tubing, since Ms. Thompson also requires antibiotics for infection to avoid interrupting the transfusion. Obtain the blood from the lab and inspect the blood bag and the documentation before leaving. Check the blood transfusion documents and patient blood bank and identification with another nurse, and both of you should sign the paperwork before beginning the transfusion. Should prime the tubing with the packed red blood cells and begin the blood product transfusion 1 hour after receiving it from the lab. Obtain set of baseline vitals 5 minutes after you begin the blood transfusion. Ask the patient care technician to stay with Mrs. Thompson for the first 15 to 30 minutes of the infusion, and stop the transfusion immediately after you see an increase in temperature of 3 degrees. So the first question is, what are the criteria that qualified Ms. Thompson to receive a blood transfusion? So currently we would define anemia as being less than 13 in males and less than 12 in females. But that being said, we do not transfuse a unit of packed red blood cells until way lower according to the evidence, just because the risk outweigh the benefits for a lot of our different diseases. So with an asymptomatic patient, until you start seeing a drop in hemoglobin until it gets below 7, you will not see a unit of packed red blood cells being ordered. There are a lot of guidelines that will raise that above 8, which will be a patient that has, cardiac disease, if they're having any kind of surgeries, or if you see a patient that is actively losing blood, or if they're symptomatic. If you see in our certain criteria here, what we're looking at is you have a patient that is below a hemoglobin level of 8, and she has a current gastrointestinal bleed. So that is really where our criteria is for this client. So even though she hasn't met that criteria of that below 7, she has a current GI bleed. She's actively losing blood. And although we don't see the symptoms of symptomatic, there may be that that would be something that we could possibly see with a client above 70 having an active GI bleed. That could be something also potentially that we would see in this client, but we don't see that in this case study. We just know that there's an active bleed, and she has a hemoglobin level lower than 8. So there are some other criteria that you might possibly see, but that's what we're seeing in this particular scenario. So the next question is, what blood types are compatible with Mrs. Thompson's blood? So we know that she has a B negative blood type. So remember, go back on the recorded lecture and it'll show you that little chart, what blood types are compatible with what. And that is really important for you to know. It's super important. That is one of the most dangerous things that can happen is you give a patient an incompatible blood type. But once again, if you have B negative blood type, that means we have a B antigen. So she cannot receive the A antigen because she does not have an A antigen. She does have a B antigen, so she can receive a B antigen. She cannot receive an A antigen. So she can receive B, she can receive O, but she cannot receive A. So she can receive she can receive B or O blood. She cannot receive AB, and she cannot receive A blood. She is negative for RH, which means if we gave her something that was positive, she would fight that. So she can only receive negative blood. So she can receive O negative or B negative blood. So she would be able to receive O negative, B negative. She could not receive O positive. She could not receive B positive. She cannot receive any A, so she cannot receive A positive or A negative. She cannot receive AB positive or AB negative. So the only thing that Miss Thompson would be able to receive would be B negative or O negative blood. So why is it important to make sure that she receives that compatible blood? And that is because she would have that risk of acute hemolytic reaction. So if we were to give her that blood that was incompatible, her body would form that, or her blood would form that antibody against the antigen that she does not have. So it would start forming that, or it would start having that reaction, it would start fighting it, and then she would start having that acute hemolytic response. And remember that we don't want to have that happening. Our body is then circulating this blood, that we have this attacking throughout our body, and then we have those symptoms where we start seeing those signs and symptoms of chills, fever, low back pain, flushing, tachycardia, hypotension, and then it turns into that vascular collapse, hypotension, hemoglobinuria because of that breakdown, and eventually acute renal failure, shock, multi-system failure, cardiac arrest, and death. And it's very, very severe, and it is not something you want to see in your patients. Your patients can potentially need, hemodialysis. They're going to need a lot of supportive care, and it could lead to cardiac arrest and death. And so it's something that is super, super concerning. And we just, it's something that's super important. You do not want to ever give a patient an incompatible blood. So then we want to look at our interventions. And so there were a lot of interventions that are not appropriate in here. And it's really important that you recognize, what are the important versus which are the correct versus incorrect interventions. So as you're going through, make sure you know the steps in giving blood. So which are appropriate, which are not appropriate. So first of all, you assess the transfusion knowledge and history of past reactions, educate the client on the process, and obtain consent. Absolutely. So you get an order for blood transfusion, the very first thing that you're going to want to do is go out and talk to the patient about that. You don't want to start the whole process of giving blood if the patient's going to absolutely refuse to give blood. You're going to go out there, you're going to figure out, well, have they ever gotten blood before? Do they want to get blood? Some patients have cultural objections to giving blood. It may be a religious objection to giving blood. It may be a cultural objection. With COVID, there was patients that didn't want to receive blood because they were completely and utterly against the COVID vaccine, and because they were not able to figure out who did or did not receive the vaccine, they refused to receive blood. And, regardless of your belief around that, whether you were for that or against that, that is their right to make that decision based on that. And then there are the one that I have seen very frequently in my practice is patients that have been Jehovah's Witness that have not wanted to receive blood because that is against their belief, that they are not able to receive blood products because it's just seen as a way, that's seen as something that they're not able to do because it is against their religious practice. And so and even at that point, you don't have to discuss their religious beliefs. You just have to let them know the risk and benefits and what that means to them, and then they get to make that decision on their own. It's not a discussion of whether, religiously what that means to them. It's only a discussion of what that means medically, and then they get to weigh those consequences, and then they get to decide. You're not there to discuss, their religious beliefs and what that means. You only just discuss what that's going to mean for them in their medical process. And then sometimes people do change their minds just based on what the outlook of that means. And sometimes people are more or less, I guess what I would say, like followers than other people are strict with their followings. So it will change to us that way. The other thing here is next thing we see is place a 20 gauge catheter. So there is nothing in this scenario that tells us that she's going to need to receive this super rapidly. So a 20 gauge catheter should be absolutely fine for this scenario. Typically what we see as a 20 gauge is perfectly fine and recommended for most blood transfusions. Typically 20 and above, perfectly fine. 22 at times can be used. Generally a 20 gauge is what most facilities have for their protocols. The 22 gauge has been used fine. You don't want to give it rapidly because that small gauge can break it down. But if you give a rapid transfusion, so if you have a blood that's giving a rapid transfusion, you need an 18 gauge or larger, and a 20 gauge or larger is typically fine for any blood transfusion. Prime a Y-type blood tubing with normal saline. Yes, this is what we use for packed red blood cells. You use a Y-type blood tubing with an inline blood filter, and normal saline is the only fluid that we use with that. So you first prime that with normal saline. And then the next thing that the nurse does is they set up a secondary infusion line to piggyback through the primary blood tubing, since she also requires antibiotics for her infection to avoid interrupting the transfusion. And the answer to this is no. And I do want to, this is still pretty early in our nursing courses. In NCLEX world, you always second, I don't know if I can do this with my mouse, but you can always get a second IV line. If you need to give antibiotics, you will get a second IV. So you now need a new IV if you need to give IV piggyback or give IV antibiotics. So you will not ever, 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 ever give anything through blood tubing other than normal saline. This is the only other thing that goes through blood tubing other than blood, normal saline, and blood. So if you need any other medications, it's going to be a secondary line. Now, this is where you'll see some disconnect through practice and protocol, because you will see 70-year-old women with blood loss, and they have low blood count. They have bad veins. So sometimes what you see is we do actually delay the blood a short time, give a piggyback antibiotic, and then go and get our blood. In NCLEX world, we do not delay our blood. We do not delay our antibiotics. We give our blood. We start a new IV line. So in practice, in NCLEX world, sometimes they don't always look the same, but in NCLEX world, we can always get an IV, always, and you will never hold either. You will always just get a new IV line. But no, you never give anything secondary through the blood tubing. So the next thing is to obtain the blood from lab and inspect the blood bag and the documentation before leaving. Yes, that is correct. And also, notice that we've already got our IV line before we ever pick up our blood. And there's a reason, remember? We've got a certain amount of time that we have before we can start our blood. That's coming out of a fridge. So we want to get this IV started, right? So before we ever leave the lab, we've already went and we've already got our IV started. We've got our IV primed and ready. And then we went and we got our blood from lab and we've inspected our blood bag and we made sure everything matches before we leave the lab. Now, in some of your facilities, they're going to send this through, but before you pick this up and start doing everything else, you're going to inspect that first thing and make sure everything matches before you start doing your other checks. So you're going to check that blood, your transfusion documents, your patient blood bank and identification with another registered nurse. It needs to be somebody that's licensed. This is not a non-licensed somebody, graduate nurse. This is not a tech off the floor. It has to be a licensed, registered nurse, and you both must sign the paperwork before you start the transfusion. Yes, this is correct. So the next one is that you're going to prime the tubing with the packed red blood cells, and you begin the blood product transfusion 1 hour after receiving it from lab, and the answer is no. And this 1 hour is the problem. It should be 30 minutes max. So I'm trying my best with my mouse to fix that. So that's the problem with this. You have 30 minutes from the time that packed red blood cells leaves that fridge to get that started. That's why you must have that IV going. That's why you prime your tubing. That's why you check it before you leave that lab. You got 30 minutes to get that bag going from the time you leave the lab until the time you get to your patient. So if you are going to get held up, you've lost a unit of blood after 30 minutes. There's no using it, because if you leave this out for a certain amount of time, it can get contaminated. You have 30 minutes to get going. The next thing says, obtain a set of baseline vitals 5 minutes after beginning the blood transfusion. That's another no, and that's because you need to get this before. You must get your vitals before, and you can get this right before you go and you get your labs, or your blood, I'm sorry. So you must get that right before. You can get it right as you walk in the room, right before you start your blood as well. I would recommend getting it right before you go and get your blood, because if you have a patient that's febrile, you're going to have this issue with you've just gotten your blood. So it's best to get this right before you go and get your blood though. The next one says ask the patient care tech to stay for the first 15 to 30 minutes. And that's also a no. And the problem is it has to be the nurse. I know that my writing is atrocious, and it has to be the nurse for 15 minutes minimum. She needs to stay with the patients 15 minutes after you start the transfusion. You will sit in this room, or he or she will sit in this room with this patient for a minimum of 15 minutes, and you will do nothing but sit in the room with the client to monitor and assess, because the first 15 minutes are when a lot of the very severe, that acute hemolytic reaction are going to occur. So that first 15 minutes, we are going to start the transfusion slowly, and then that, and you can see this on those, the lecture, the recorded lecture, you start it very slowly, and then after that 15 minutes, you get your vitals, and then you're going to increase your transfusion into the prescribed rate, and it must be the registered nurse that starts the transfusion. And then where it says stop the transfusion immediately after an increase in temperature of 3 degrees. Yes. So if you see any signs of any of our transfusion reactions, you must stop the transfusion immediately, which, that brings us to 4. Why should a nurse stop a transfusion immediately if a reaction is suspected? So why do you stop this immediately? So if I think there's a transfusion that's happening, why is it important that I stop that transfusion immediately? That means if I stop that blood from going in immediately, I stop more blood from getting in. So whatever is causing the reaction, that means I have less of it in my system if I stop it. So all that's doing is less circulating blood. I can stop, I can make the reaction smaller. So I am able to like mitigate and decrease the amount of the reaction that can occur by stopping it as soon as it is caught. So this asks for what interventions should the nurse perform. And of course, the first one is stop. I wish I could type better. First is stop. The second one is to disconnect. I don't know if I'm going to write all of this out. Very important to disconnect. I can't spell, and that's okay. Disconnect, and then it's new tubing, IV saline. Okay, so there's a bunch more of this that's going to follow this. So you stop the tubing or stop the transfusion 100% every single time. Stop it immediately. Disconnect the blood tubing. You get new tubing with IV saline at least KVO rate, because we need a line going, right? Because this could be potentially very serious with a transfusion. And this is every single reaction. This does not change depending on the reaction. So stop, disconnect, new tubing, IV saline running, right? So after that point, that's when we start calling the doctor, starting our treatment, sending off our blood tubing and our blood back to lab, monitoring our vitals, and treating per the type of reaction. Okay, so Miss Emily Rodriguez, a 28-year-old female, she's scheduled for a blood transfusion, and she's recently been diagnosed with iron deficiency anemia secondary to heavy menstrual bleeding, and she's scheduled to receive a transfusion of packed red blood cells to address her anemia. She has experienced a mild allergic reaction during a previous blood transfusion. So because she has received this mild allergic reaction during a previous blood transfusion, that does not necessarily mean that she can never receive a blood transfusion before, especially because it's mild, obviously, and because she has a low enough H&H in this case. We don't know the number, but we're going to assume, she's having heavy menstrual bleeding, or she has had heavy menstrual bleeding. We're assuming it's low enough, probably under or around the 7, or she's symptomatic. That hemoglobin level is probably rather low with that being 28-year-old, or she's very symptomatic. So we're assuming that they're going to want to pre-treat her. So what pre-treatments might we give to Miss Rodriguez, and why and when should we give these treatments? So because it's a mild allergic reaction, we can just pre-treat her with some medications and we will just watch her more closely. So this mild allergic reaction is going to be due to some sensitivity to the plasma proteins, and it's going to present just like an allergic reaction would to other types of medications, and we can give an antihistamine, pre-medicate her with that, like we would if we were going to give her something that she was allergic to. We could pre-medicate her prior to the blood transfusion to try to stop that from occurring because she needs this blood. So if we weren't aware that she had an allergic reaction and she were having a transfusion and had an allergic reaction, we would still stop the transfusion just like always. If she has an allergic reaction during the transfusion, we would still stop the transfusion just like always. So we're pre-medicating her in an effort to stop her from having a transfusion reaction. So prior to treatment, we want to give her an antihistamine to stop that reaction from occurring. So most likely she's going to be given most likely diphenhydramine. There are of course other antihistamines out there, but this is just kind of that tried and true classic that we see given most often as pre-treatment. So when we ask when should it be given, that means we should be giving it to her early enough to have it in her system before we introduce what is going to be causing the reaction. So in this case, before her transfusion begins, and that it's circulating in her system. And so when we look at oral medications, most of the time, they're going to take a little bit of time to absorb. We want to have them onset, potentially near peak, or at least on onset. With diphenhydramine, it's going to be 30 to 60 minutes before we have onset. So typically, you're going to give it about an hour before transfusion begins. So at least an hour before transfusion begins. The peak is going to be 1 to 2 hours. So if you give it an hour before, it's going to be really circulating by the time that transfusion begins. It's going to be peaking. You're going to have a very good chance to have that circulating and stop that transfusion reaction from occurring. So one of the questions that's not actually on here, but it's just an important thing to think of, how do you know the difference between a mild transfusion reaction and a more severe? More severe symptoms. A mild allergic reaction is going to be things, the flushing, the itching, the urticaria, which is just that fancy word for hives, and you really do need to know urticaria means hives, so you're going to have that rash, that itchy hives that you see throughout the body, through the body. Whereas an anaphylactic, you're going to see the patients having those respiratory symptoms. You're going to see the cyanosis. You're going to have the wheezing, and they're going to have the inability to breathe as well. The wheezing, the closing of the airways, anxiety because they're not getting the oxygen, and it can even lead into cardiac arrest because they're not moving air. So it is more severe. So those patients may even need CPR. They may need epinephrine, whereas a mild allergic reaction, you're looking at just antihistamines. So even though that wasn't one of the questions, it is important to recognize the difference between severe and mild reactions, whereas mild is going to be rashes, itching, anaphylaxis. You're talking about severe respiratory type things as well. What if the patient has like a mild febrile reaction? Some of these patients will have febrile reactions because some patients have like sensitizations to like white blood cells, and they often will have febrile reactions, and they often need pre-treatments as well. And when you think about what pre-treatments that you have for febrile, we have antipyretics, and those are going to be like your Tylenol, so your acetaminophen. And the same thing happens with those. You need to have those within their symptoms for about an hour before, so that that's circulating within the blood as well, so that that's going to be ready to go, and it's going to keep the temperature down. And so you can, hopefully what you see is that you're going to stop that reaction from occurring. You don't see the febrile reaction that occurs as well. But remember, just because you're treating it to stop it from occurring, so if the patient has the reaction, you still have to treat the reaction that occurs in there. So you still can pre-treat for a patient that has a history of reactions though. All right, so you're a nurse working in the medical surgical unit of the hospital, and one of your patients, Mr. Johnson, is a 55-year-old male. He's been admitted with severe anemia due to chronic kidney disease. His hemoglobin level is 6.5, and he's scheduled to receive a blood transfusion of 3 units of packed red blood cells. After completing all of the pre-procedure steps, you begin the transfusion. So looking at the scenario, what criteria did Mr. Johnson meet for the transfusion? So we don't have anything to tell us that he is symptomatic or that he's currently losing blood or he's having any procedures, but we do see for sure that he has that hemoglobin level less than 7.0. So we do know that he has that hemoglobin level under that 7 levels, so he does meet that criteria for the blood transfusion. Him receiving 3 units tells me that, you know, he may have some other criteria, some symptomatic criteria possibly, because he has the chronic kidney disease, which you guys haven't learned all the kidney disease information yet. He probably, you know, he's definitely not able to make red blood cells because of the lack of erythropoietin. So that's why his levels are low, most likely. So that's probably what's going on with our level 1. So how long does the nurse need to stay in the room to observe the patient? So she completes the pre-procedure steps, and after beginning the transfusion, so when we begin the transfusion, we need to stay in the room for at least 15 minutes. Now, I don't think that this is, as far as I can tell, looking at all the evidence-based information from the American Red Cross and the NIH and all of that, there seems to be no actual like set, you must stay in the room for 15 minutes. But this is the protocol everywhere I go. This is in the nursing textbooks. This is, you know, if you review the NCLEX, everywhere says 15 minutes at least is recommended. So any facility that I have ever been in has this policy. So and it will be on the NCLEX, you will wait 15 minutes in the room with the patient. And so you'll be observing them, and it's about 2 mils per minute, so 30 mils an hour, that you're going to sit here and you're going to go at a very slow rate. So 30 mils an hour, 2 mils a minute, whichever. So the rate is 30 mils an hour. So at that 15-minute rate, you're going to do a set of vitals. You're going to make sure they have no febrile reactions. You're going to make sure the blood pressure, the heart rate, everything else is okay. You're going to assess that patient, make sure they're feeling okay. And that's that. When does the patient take the next set of vitals? That also answers that. And then you're going to increase that to the prescribed rate of transfusion. So looking at this, based on this patient's health history, what transfusion reactions would they be at risk for, and how would you recognize this? So if you look at this patient, they have chronic kidney disease, which means they're not going to be filtering out fluid well. So patients with chronic kidney disease are going to be at risk for fluid volume excess. And there is, in particular, a circulatory overload or transfusion-associated circulatory overload, or TACO, T-A-C-O, that is very specific for patients that are at higher risk for circulatory overload. So Mr. Johnson is going to be at higher risk for that type of reaction. And how would you recognize it? So we're fluid volume excess, that's going to be how we're going to recognize it. So we're looking for signs of fluid volume excess. So we're going to be seeing signs of cough, dyspnea, pulmonary congestion, crackles, headache, hypertension, tachycardia, distended neck veins. So remember on your health assessment when you saw the shadow for the JVD, that's your distended neck vein, so your JVD. The cough and dyspnea is because we have fluid in our lungs. The crackles from fluid in our lungs. The headache because we have increased pressure and extra fluid. Hypertension because the extra blood volume. Tachycardia because our heart rates increase because of the extra blood volume. And we're going to see edema. So we have extra blood volume causing edema. We're going to recognize it, and it's a more of a slower onset than we see with our lung shortness of breath and congestion that we see. Whereas with the TRALI that we talk about with the pulmonary congestion and shortness of breath, with that happens really suddenly. With the circulatory overload, it happens a little bit over time. In fact, it can happen hours after the transfusion ends because it's just because our body can't handle the extra volume. And so you recognize it because it comes on as the transfusion continues, and it doesn't happen just kind of quickly as a quick reaction to the transfusion. It comes on slowly as the volume builds up, as the patient cannot handle it. Just like if you would give them any fluid, it's overload related to the transfusion and the extra volume. So what post-transfusion laboratory testing would you expect to see completed, and what findings would you expect to see? So the main thing we're looking for, and what we're looking for with blood, is we're going to test to make sure that our blood levels have increased. So if we have a hemoglobin level of 6.5, we would always expect our hemoglobin, barring any active bleeding, we would expect our hemoglobin level to increase approximately 1 gram per deciliter per unit given. So if we had a level of 6.5, we would expect it to increase to about 9.5 if we gave 3 units. So if we gave 1 unit, it would only be 7.5, but with Mr. Johnson, we would expect to see about a 9.5 after transfusion for this client. So remember, one increase per unit. So that's what we would expect to see with our clients. Okay, so you're a nurse, you work in the ED, and a 30-year-old female patient comes in. This is Miss Santana. She comes in with sickle cell disease. She has an acute vaso-occlusive crisis. So when she comes in, her hemoglobin is 7.2, so she's very close to that cutoff point, and she's in significant pain. So she's getting that transfusion of packed red blood cells that has just started. So after initiating the infusion, you notice flushing on Miss Rodriguez's face. She has urticaria on her arms. Remember, that's that fancy word for the hives. So she has that itchy hives, and she reports that mild itching in those upper extremities. So what reaction would you suspect based on the above scenario, and why? Remember, we talked in our earlier slides that would be that sign of that mild allergic reaction, which is caused by those that reaction to those proteins in the donor blood. And how would you differentiate between the mild and the more severe reaction? Remember, with the mild, we're just really having the hives, urticaria, and the flushing of the face. Or the hives is the urticaria, sorry, the itching, the urticaria, and the flushing of the face. And when we start seeing the more severe, where we start looking into the anaphylactic type reactions, we're seeing the respiratory, we're hearing the wheezing, we're seeing the shortness of breath, we're seeing the cyanosis, and that can even progress into cardiovascular CPR type necessary, or CPR type reactions, so cardiovascular collapse. So what treatment might you expect? this is a reaction, you stop the blood transfusion, you disconnect, and you start an IV normal saline before you do anything else. With mild allergic reactions, with these, physicians often will go ahead and restart them after you administer either IV antihistamines or PO antihistamines. Typically, it's going to be IV because we have an IV in place. We want to get that started. We have blood going, so you're going to see an IV diphenhydramine, and you're going to monitor them very closely. Really, no other transfusion reaction technically should be restarted. Now, in actual reality, you will see febrile reactions in clinical reality that will get started. And what's actually happening is the physicians aren't seeing those as febrile reactions. They're seeing them as the patient is having fevers, typically for other reasons. And they're reading as febrile reactions just because technically they're having a fever when on blood. So you may see what are technically seen as febrile reactions be restarted, but technically allergic reactions will still sometimes be restarted. Sometimes, though, the physicians will choose not to, especially if you have a patient that's had a severe history, or if they've had history of anaphylaxis, or if they've had bad asthma. It's really all going to be case by case. But this patient treatment, it's going to be the same up to the point where we call the physician, and then we may see antihistamine and restarting, or we may go into our normal, sending the blood and the blood tubing to transfusion services or the blood bank or lab or whoever at your facility is the person that handles that, and doing the incident report, blood reaction reports, and the follow-up and the care and the monitoring that goes along with that. All right, so Mr. Khan, he's a 45-year-old male, and he's scheduled for a major surgery to replace a hip in 2 months. So despite the recommendation for blood transfusion support during the surgery, Mr. Khan adamantly refuses to receive donor blood due to a history of a severe reaction. So he doesn't have a moral problem with it. He is adamant. He doesn't want to receive blood. He's had a severe reaction, and he just is adamant. There's no talking him out of it. So his concerns, he's deeply concerned about the potential for blood loss during the surgery and its implication on his health and recovery. His family supports his decision regarding blood transfusion and is actively involved in his care and decision-making process. So what ethical considerations arise when a patient's religious beliefs conflict with the recommended medical treatment, such as a blood transfusion? And in his case, it is not his religious beliefs, so it's a little bit different. But with religious beliefs or any beliefs, what ethical considerations arise? And it's really a tough place to be when you, as a nursing person, and it doesn't have to just be religious beliefs. In this case, the belief is he's had a severe reaction. He doesn't want to get blood. And here's a problem that we're going to have is that if he was to lose blood during the surgery, it could negatively affect his healing process, and he could have a potential health crisis, and we would not have the proper treatment to treat him. We have that ethical consideration is, we have this surgery that we're going to continue with, but then we may have that dilemma is, do we continue with the surgery knowing that if he had blood loss, then we had this potential situation that were to arise that we do not have the proper treatment for. So then we're looking at, yes, we can continue, but he needs to know all of the risk and benefits. And really, what it all falls out to is making sure that patients and patients' family are completely and utterly aware of all the risk and benefits that come along with it. So when they're going into something like a surgical procedure where they're likely to lose a lot of blood, they just need to be aware of what the risks are for that. So if they were to lose a lot of blood, they need to understand what happens when that perfusion drops and that risk of that multi-organ failure and how that could affect them, even to the point where they could have cardiovascular collapse, they could have neurological deficits that could occur. And they just need to be fully aware. And they still need to have that autonomy and that ability to make their own decisions as well. So how can healthcare providers respect and support that patient's autonomy while ensuring they receive that appropriate medical care? So it's kind of that same thing. So with the thing is, what are the ethical considerations? We need to be fully aware going into that, knowing that they have that right and that autonomy to make those decisions, but we also need to make sure that they are fully aware, and we need to respect and support that, but we also need to make sure that they have the capacity and the understanding to know exactly what is going to happen, and they're fully understanding the process and the implications of the decisions they make. And when they do, then that's on them, and that's their right, because we don't do any harm, and we also do not make adults and people that are able to make their own decisions. We do not force decisions on them because that is their rights as independent people to make those decisions. So then it kind of falls into, well, then what else can we do? So then that falls into this other answers. What alternative strategies can be explored? Whereas you go back into the lecture, the recorded lecture, and we talk about that autologous blood donation. So there's different things that we could do. So Mr. Khan here is not doing this for a religious purpose. So he's not a Jehovah's Witness. So we have a lot of different things that we can do for him. So he had a severe reaction. So most likely this is a reaction to something in a donor's blood. So he looks like he's healthy. He's a 45-year-old male. He's very healthy. If we're worried about blood loss, we have a possibility to do autologous blood donations where he can bank his blood. And then we are going to have so much less risk of having those reactions to his own blood than we are for others. And he is going to have that ability to build up that blood level as well before he goes in to have a surgery, because they have these different criteria. So when you're donating the autologous blood, and this is on the lecture, of course, you must begin within 5 weeks of the surgery because blood can only be stored for a limited amount of time, and you must end at least 3 days before the date of the transfusion. So this gives you time to rebuild that hemoglobin level. Your hemoglobin level must be above the level of the donor requirement. So he would need to be above that 13 level. And he can donate every 3 days as long as it stays above that safe level, and as long as his blood pressure and his temperature and all of that remains above that safe level. So he could come in and just bank this blood. And so he can donate that and have that available for him in case he needs that for a surgery. And then he would have this less risk for him. So now if he were Jehovah's Witness, they would still not be able to use this blood. So that would still be against their religious belief. They could, however, use autologous blood that was done through blood salvage during the surgery. So this would be done where they suction the blood as it is lost in the closed cavities during surgery, and it goes in and it gets filtered, and then it gets immediately put back into the body because it doesn't get processed the same. It's considered as to like not have ever actually like left their body because it just kind of gets reintroduced. So that is not considered the same as a blood donation. So that would be another way that blood loss could be prevented. And I believe that was actually, that may have actually been introduced for patients like Jehovah's Witness that could not receive blood transfusions due to the religious convictions. So that would be another alternative strategy that could be done during a surgical procedure to prevent blood loss. All right, so Mr. James Wilson, he's a 65-year-old male, admitted to the hospital for severe anemia, second to a GI bleed. He's receiving blood transfusion of packed red blood cells to address that anemia. 15 minutes after the nurse initiated the blood transfusion, he started to experience low back pain, flushing of the skin, tachycardia of 120, and hypotension of 80 to 50. Okay, so I'm going to tell you right now, this this low back pain, tachycardia, hypotension, this is all going to show us that we're starting to see renal issues. We're starting to see a fluid volume deficit, tachycardia and hypotension. We're seeing this flushing in the skin. What we're seeing right here, why do you suspect is happening and why? We're seeing a acute hemolytic reaction, and it's 15 minutes after the nurse, so we're seeing it very early. So what we're seeing is a hemolytic reaction, most likely, and that's why. Why are we seeing it? It's early. We're seeing all these different signs, that low back pain, we're seeing that elevated heart rate and that low blood pressure, tachycardia, or that's the heart rate, and the flushing of the skin. These are all signs of that. So our very first action, stop the blood. What's our next action? Disconnect the tubing. Next action after that, new tubing with normal saline. Then we start calling doctors. We start sending tubing and blood bags off to the lab. We get some urine to test for hemoglobinuria. We get labs. We're going to monitor our patient. We're going to be doing all of our interventions because we're going to be looking for this multi-system organ damage that may have occurred due to that. Okay, so how long do we have to start the transfusion after obtaining blood from the blood bank? And that is going to be 30 minutes. That clock starts as soon as they give you that blood from that refrigerator. If it's 31 minutes, you've lost your unit of blood, you must throw it away. That's why we must start our IV before we go get our blood, because you do not want to have a hard stick that you are trying to mess with and you lose your blood. You must have your blood tubing primed because you don't want to have to mess with that. You want to have your baseline vitals taken because you don't want to find out your patient is febrile and try to figure out if you're even going to give the blood because you've now taken it from a controlled unit. So we want to get our stuff done before we go get our blood. How long do we have to complete a transfusion? For, that should say hours. And that starts when that starts. So as soon as we take that from that controlled environment, this clock starts. So if we get this out at 3:30 p.m., we have till 7:30 p.m. to get this done. So this counts when this starts. So it's not when we start the transfusion, it's when we pull it from lab. When do we change the blood tubing? Every 2 units or every 4 hours. So it's whichever one is first. Okay. And what other risks do we have, especially with multiple transfusions? So first of all, with multiple transfusions, you're going to have an increased risk of reactions. So the more transfusions someone has, the increased risk of the reaction. And this is kind of, for the most part, true. So if you think about it, a patient is just going to be at increased sensitization overall, increased risk of allergies, increased risk of febrile reaction. If they're having more fluid, they're going to be increased risk of overload. They're going to be increased risk of TRALI. So everything is just increased risk overall. Also, they're going to have an increased risk of hyperkalemia. So you'll learn a little bit more about kind of how potassium releases out of the cell as it gets destroyed, or as cells get destroyed. Red blood cells, no exception to that. As blood, the older blood is, the more destruction we're going to see. So the older blood is, the more risk they are for hyperkalemia, but also the more blood you have, the more risk you are for hyperkalemia. So the more blood you have, the hyperkalemia, more risk of hyperkalemia you have. Also, just because of the risk of, oh my goodness, just because of the risk of the action of citrated blood as it combines with ionized calcium in blood, you're going to have an increased risk of hypocalcemia, and calcium gluconate is going to be administered when you get multiple units. So every 4 to 5, so I'm going to say hypocalcemia, so hypocalcemia. So every 4 to 5 units, you're going to get calcium gluconate administered. It's going to be a little bit different each facility, just depending on their protocols, but it's usually every 4 to 5 units because of this increased risk of hypocalcemia. And I think those are kind of the main things that I want you to know about.